It's story time. Tell the story of abdominal cavity and peritoneum. Now, what are we going to do? First of all, be calm and enjoy learning. Now, don't be tense. You have been tense for some years. Calm down and learn medicine. Calm down, relax. You learn better. Now, because we will be talking about the abdominal cavity and abdominal organs, now, the first step is we need to activate our prior knowledge. يعني في سنة أولى خدتوا الجاستروintestinal system. So we are going to use it. How? Revising it. Reading lots of books. Why? Just because we're going to learn new knowledge and we're going to build on it, on previous knowledge. ما ينفع أن الإنسان يتعلم في سنة دراسية بعدين شو بيعمل؟ ينظف الطاولة ويبلش من جديد. لا. We are building knowledge till we reach what we need. And what we need is going up steps, going upstairs to reach our goal. We need to upgrade our knowledge. Why? Because next year we will face reality. And you can do it by remembering, understanding, applying, analyzing, and being creative. You know the abdominal cavity now, roof, floor, anterior wall, posterior wall. This is reality. This is next year reality, and then from there onward. No lines, no colors, no colored images, right? Anterior abdominal wall. Abdominal problems are common. Examine the abdomen. There is no drawing on the patient. There is no colors on the abdominal wall. So you use your knowledge. Therefore, this is what you are going to see. Therefore, it is time to change our way of thinking. We want to face reality. No colors, no colored images. But we will use them every now and then. And we have a very good idea where organs are. Now, we open the anterior abdominal wall. In a living person, we can see that the abdominal wall is shining. This is the lining of the peritoneum. And we can see that even different organs, and the abdomen is crowded with organs. And we can see these different organs also shining, reflecting light, because everything is covered by peritoneum. If you open the abdominal wall in a cadaver, also you see the abdomen is full of organs. An organ to the right, an organ to the left, and you can see this greater omentum, and still organs are shining. Still the peritoneum is shining. The peritoneum is a very important serous membrane, and inflammation of the peritoneum, which is called peritonitis, can be fatal. So we have to know very good knowledge of that. And we need to check the nerve supply on the mind map. Let's start with some embryology, simple embryology. In this image, this is the abdominal cavity lined with a peritoneum, and there is nothing in it. So it's a big sac. It's a big sac. Then later, things will develop, things like, meaning organs. Things develop in the midline posterior abdominal wall. Some of them stay in the posterior abdominal wall, covered by peritoneum. Some of them get longer and bulge into the greater sac of the peritoneum. Then things get more developed, organs develop. And as organs develop, we get a pocket here, right? A space here, a space here. So things will get more complicated. We will look into these pouches and pockets and recesses. So this is the peritoneal lining of the abdominal cavity. This is parietal peritoneum, lining the abdominal wall. Then we go to the posterior midline. We will find organs developing here. This organ was here, but because it gets so long, it is طلعي على الشاشة لا على التليفون. It is going to bulge into the sac. اسمعي المحاضرة لا تسمعين التليفون. طب افتحي أذانك الاثنين. So when it comes and bulges into the peritoneal cavity, it will take peritoneal cover with it. Then the peritoneum is going to cover this organ. Once it covers this organ, it is going to be visceral peritoneum, a peritoneum covering an organ. Not parietal peritoneum, which is a peritoneum covering an abdominal wall. Then this visceral peritoneum will go back to the posterior abdominal wall, and this is called a mesentery. What is a mesentery? The image is telling you it is double layer of peritoneum going from the posterior abdominal wall to cover an organ. Okay? This image is telling you the definition. This is the root of the mesentery, where it stems from, where it comes from. This is a mesentery. double layer of peritoneum, then things become more complicated, more developed. This is also double layer of peritoneum. But the image is telling you what? It is not attached to the posterior abdominal wall. It is from one organ to another. Right? So this is an omentum. This is the definition of an omentum. Then things develop. Organs get bigger. Some organs get longer. Now they cannot stay in the midline. They need to be what? Rearranged, put in place where the abdominal cavity can take these organs. So the greater sac will start to have pouches. This is the greater sac. Pouches, pockets, spaces, ligaments. A ligament, this is also a double layer of peritoneum, but very short one. And it is between an organ and abdominal wall. So let's come to this drawing. Here is the peritoneum of posterior abdominal wall. There are organs in front and there are organs to the back of the peritoneum. The organs to the back of the peritoneum are called retroperitoneal organs. Can I see a real peritoneum? Yes, this is the peritoneum. It's simple squamous mesothelial cells with little connective tissue deep to it. Very shiny, very smooth. That's why it's there. حتى الأورجانز بتتحرك فوق بعضها. You don't feel it. It's a smooth surface on a smooth surface. Again, this is an opened abdomen where you can see that the peritoneum is a real structure. It's not an imaginary structure, wala microscopic. This is the falciform ligament between anterior abdominal wall and the liver. So the peritoneum overview is that it is a serous membrane. It's not mucus. Mucus is a lining of an opened cavity. Abdominal cavity is closed. It is the largest serous membrane. And the pleura is a serous membrane. And the pericardium is a serous membrane. But this is the largest because the abdominal cavity is the largest and most complex. Why is it most complex? When the organs grew in size and length and rearranged. Therefore, it is not that you open the pleura, you see the lung. No, it's not like this. It's that you open the abdomen, you try to put your hand into different pockets and other structures. This serous membrane lines abdominal cavity, abdominal walls, anterior, posterior, under surface of diaphragm, and lines the pelvic cavity, which is the lower part of the abdominal cavity, walls and floor. All this is parietal peritoneum, right? covering no organ. In places it leaves posterior abdominal wall, the diaphragm, pelvic floor, and covering an organ. And the peritoneum covering an organ is called what? It's called visceral peritoneum. When organs get larger and longer and rearranged, it starts to have pouches. Greater sac, this is the original big peritoneal cavity, which is not big anymore. Lesser sac, a space behind the stomach. It has little recesses around the duodenum, around the cecum, around the sigmoid. Spaces under the diaphragm. Gutters. A gutter means sapia. Around the large intestine. So this is the little spaces between organs. This is what we see in a CT scan. Okay? When you have a patient with a problem, you are not sure what is the problem, you don't open the abdomen of the patient because it is a big trauma. You take a CT scan and you can see how things are arranged, and the abdominal cavity is so crowded. In the next few lectures we will learn which is which. Now, when you open the abdominal cavity, you are in the greater sac. The next in size is the lesser sac. It is a space behind or posterior to the stomach, but still connected. And you can put your finger into this space. It's called epiploic foramen of Winslow. Here is a person putting the finger in foramen of Winslow going into the lesser sac. This is the stomach. This is the duodenum. You know why it's green, dark green? Because it contains bile. This is the liver. And this person is passing the finger from the greater sac into the lesser sac, which is posterior to the stomach. This is a CT scan. Here is the stomach. Okay. This is the pancreas. And this space behind the stomach is the sac. It's a space behind the stomach. Simple. This is a diagram of the arrow indicating passing from the greater sac into the lesser sac. Here the lesser sac is opened around the stomach, and you can see that there is spleen, celiac trunk with its branches. Let's come to this figure again. Which organ is this? Stomach. This is a space behind the stomach. This is the lesser sac. the small intestine here, held by the hand, and you can see this is the mesentery of the small intestine. It has a root. This is the root of the small intestine, and then follow the red lines. This is the root of the small intestine. This is 25 centimeters long. The small intestine is around 6 meters. So how can I attach 6 meters to the 25 centimeters? The answer is corrugated. Right? This is a CT scan showing you the root of the small intestine, because this is the small intestine. We will learn why this is a small intestine. This is the small intestine marked green, and you can see how it is arranged. Okay, because it's so long and the root is so short. And this blue structure is the mesentery, and we know what a mesentery is now. This is the mesentery, very thin double layer of peritoneum containing blood vessels, and these are the loops of the small intestine. This is the mesentery of the small intestine marked green. Back to this figure. This is a loop of small intestine, another loop, another loop, another loop. And this is one of the corrugation, another one, and they end up at the root of the mesentery. Which structure is this? Duodenum, marked green. Which structure is this? That's the pancreas. This is duodenojejunal flexure. And this is last part of terminal ileum, joining the cecum. And this is the root of the small mesentery of small intestine, oblique. Parietal peritoneum, this black line indicating the small intestine with its mesentery, double layer attaching the small intestine to the posterior abdominal wall. This arrow is pointing at visceral peritoneum. Back to CT scan image of the abdomen. This is a loop, large loop of small intestine. The mesentery is going this way to be attached to the root of the small intestine. Which organ is this? Transverse colon. And you can see that it has a mesentery called mesocolon, and it goes back to the posterior abdominal wall and attaches itself to it. Which organ is this? Lower part of the large intestine on the left is the sigmoid colon, and it also has a mesentery with the blood vessels. So this is the duodenojejunal flexure, the start of the mesentery of the small intestine. And this is where the terminal ileum joins cecum. This is the root of small intestine. Then this is the ascending colon. Ascending colon is retroperitoneal. And we know now what is retroperitoneal. Right? At the hepatic flexure, the transverse colon begins and it has a mesentery, so it has a root on the posterior abdominal wall. This is what? End of transverse colon and beginning of descending colon. Descending colon has no mesentery. Sigmoid colon has a mesentery, a V shape. Now, this part of the greater sac is called supracolic compartment. This part of the greater sac is called infracolic compartment. There is one on the right and there is one on the left. So what are the compartments of abdominal cavity? It is supracolic and infracolic. Infracolic is divided into right and left. Here's the stomach cut. And this is the duodenum. If we have perforated duodenal ulcer or posterior gastric, fluid comes out. When the fluid comes out of an organ, if it comes this way, the root of mesocolon is going to stop it. It cannot go down. So the fluid will go to the right and then pass through right paracolic gutter, right, and ends up in the pelvis. And we like that. We can drain this fluid. We like that. If lower part of the duodenum is perforated for some reason, the collection of the fluid will be in the right infracolic compartment. Now, the fluid starts to collect here. No way to escape lower down till it fills all the right. يعني اقعدوا اسمعوا لكم كلمة، اسمعوا لكم جملة، شوفوا لكم صورة. Till this space is filled, then it spills over, and then goes to the left infracolic وتنزل إلى البلبس. في عندنا left paracolic gutter. هذه there is no organ that can rupture and collect fluid there. Okay, so this is why we learn compartments of peritoneal cavity. This is the lateral abdominal wall. This is the cecum, and this is the right paracolic gutter. Back to this image. Which organ is this? This is the liver, and this is the stomach. Here is a double layer of peritoneum between liver and stomach. Has nothing to do with the posterior abdominal wall. It's from one organ to another. Therefore, this is an omentum. Double layer of peritoneum from the lesser curvature of the stomach that goes to the liver. This is lesser omentum. This is marked green because this is stomach. Now we look into this huge curtain along the greater curvature of the stomach, covering most organs. This is marked green. Which organ is this? This is the stomach. Double layer of peritoneum, one from anterior, one from posterior, through the greater curvature of the stomach. These two layers, they come down. Okay? They come down for a variable distance. Then turn back. And two layers, they turn back on themselves. When they turn back on themselves, the structure becomes 4 layers of peritoneum. And they go up and attach to this organ, which is the transverse column. This is the greater omentum. Parietal peritoneum, falciform ligaments. This is the liver. Spaces and peritoneum of the liver. Right lobe, left lobe. Falciform ligaments, which we have just seen. 2 layers of peritoneum. They split. One goes to the right and then attaches to the diaphragm. Turns back. When it turns back, this is called right triangular ligament, and goes back to the liver. On the left, same thing. Turns back, left triangular ligament, and then goes back to meet the right one. The end result is a circle of ligaments, a circle of peritoneal folds called coronary ligament. And inside the coronary ligament is the bare area of the liver. Liver not covered by peritoneum. In a diagram, same thing. Pockets of peritoneal cavity between liver and diaphragm. Okay. This space here is anterior subphrenic space, right one, because the diaphragm comes and covers the liver. And this space here is left anterior subdiaphragmatic space. When you go to the back, it is left posterior subphrenic and right posterior subphrenic. This is the falciform ligament. This is a CT scan of a patient. This is the liver. The this patient has fluid filling the abdomen, and this is a space to the right of falciform ligament, which is at the tip of the red arrow. So this is anterior subphrenic space, and this is posterior subphrenic space. This is what we hate the most. Why we hate this? Because it is difficult to reach. There's fluid in the abdomen, coagulates, gets jelly-like and solid, and it has to be taken out. But the space is deep and difficult to reach. Morrison space is called hepatorenal space. This patient has collection of fluid in the space between the kidney and the liver. This is the right hepatic lobe, right kidney, and you reflect the liver and you put your hand this way, it goes very deep. Collection of fluid there is difficult. You see, this is the liver, this is the kidney, this is the hepatorenal pouch or Morrison's pouch. This is Morrison's pouch, and it is here. Here the liver is being cut, and this is the kidney, and this is space here. Lower down in the pelvis, the peritoneum covers the organs and makes pouches as well. This is a case of female because this is the uterus. This is the urinary bladder. This pouch between the uterus and the rectum is called pouch of Douglas. Fluid, this is very dependent. Fluid collects here, and we like that because we go through the rectum, puncture this, and fluid is out without an operation. But we have to make sure that the fluid collects here. And this pouch here is called vesico-uterine pouch. This is vesico-uterine, and this is pouch of Douglas. The two pouches. Look at this area here. This is the line that separates the duodenum from the jejunum. It's a ligament called ligament of Treats. There are, as the jejunum starts to get a mesentery, there are little pouches there. They are called paraduodenal pouches or recesses. If you look at this area here, this is the cecum, and you have paracecal recesses. Usually the appendix hides in one of these recesses. The sigmoid colon also has its own recess. So these are paraduodenal, paracecal, and parasigmoid. This is the pelvis, this is the urinary bladder, and this is the uterus. These are fallopian tubes.
Actually, I couldn't find that contact. Could you tell me again?
Sorry for that. And the green structure is double layer of peritoneum. It's called the broad ligament. Actually, it's the mesentery of fallopian tube. The red line, the red structure here is the fallopian tube. This is a CT scan of the broad ligament that divides the pelvic cavity into anterior and posterior parts. This is a fluid in the peritoneal cavity, and we want the fluid to collect in the pelvis. Therefore, we put the patient into this position. Okay? If we put the patient in a supine position, the fluid, this lordosis is that of the lumbar. Some will collect in the pelvis, but we hate collection there because it goes to Morrison pouch and goes to the subhepatic or subdiaphragmatic spaces, which are difficult to clean. Therefore, the best thing is Fowler's position. Never Trendelenburg. That's why you see patients in hospital are lying in this way. Nerve supply of the peritoneum. There's a parietal peritoneum and visceral peritoneum. And we know what is parietal and what is visceral. Parietal is sensitive to pain, temperature, touch, and pressure, just like skin. Lining anterior abdominal wall and supplied by lower 6 thoracic and first lumbar nerves. The diaphragm is supplied in the central part by the phrenic nerve and the peripheral part by lower 6 thoracic nerve. Pelvic region is the obturator nerve. If the parietal peritoneum is stimulated, the patient can tell you that the pain is here or here. Can point the finger at. Visceral peritoneum, and we know what is visceral peritoneum. Peritoneum covering the liver, for example, or the stomach, or the small intestine. Is sensitive only to stretch and tearing. Okay? It's not sensitive to pain or touch or pressure. Excessive stretching, excessive tearing will produce pain. This pain is very limited, less severe, referred to abdominal wall. يعني ما يقول لك كبدي يوجعني، اوكي، او يقول لك مرارتي توجعني، لا. It is sympathetic afferent، يعني من الأورجن إلى spinal cord autonomic، اوكي، تروح supplying the underlying surface over distension of a viscous, stretch of a viscous or recovery of a visceral peritoneum will give us pain. Okay? يعني قصة البين من الابdominal wall is simple. بس قصة البين from an organ is not simple. The appendix تهبط. Okay? It's an organ. صار عليها stretching بدل pain. تروح تسأل المريض أو هو المريض بيجيك تقول له وين الألم؟ يتردد حتى يأشر. يتردد حتى يأشر. ولا يعني ما يصرخ من الألم. بس إذا أنت فهمان بتقول له أنت لما جيت بالسيارة كيف المطبات معاك السيارة؟ يقول لك كل مطب الألم يصير هون. ليش؟ لأنه هاي المطب الانتستين جسم يتحرك، الانتستين تتحرك، تقوم الابندكس تلامس البارايتال. اوكي، بارايتال از sensitive. فيقول لك في كل مطب الألم هون، بس هسه يعني يروح هيك بس ما يقدر يأشر بالضبط، بس لما يصير touching the parietal يقول لك الألم هون. That's why we learn nerve supply of the peritoneum. هذا راح تشوف في المستقبل كثير. شكرا يا شباب.